Welcome back, Journal Clubbers. Ed Bowder and Dan Schwester on the Overrun. Today, we are going to talk about strokes and how well we're doing with them. And those who have watched the show will be blown away to know that, not great.
Well, in this study.
In this particular study. So what we're looking at today, this is how do interventions to improve the efficacy of acute stroke care affect pre-hospital times. This is a systematic review and narrative synthesis. This comes out of the British Emergency Medicine. This is from McClellan et al. So here we see in this background, and again, we're going to go through this whole study, but they wanted to see how effective EMS interventions actually were in reducing what we call EMS, on-scene time, EMS to needle type of interventions here. So essentially, is anything that we do in the field reducing patients' times and actually improving their outcomes? It did not look at specific interventions. It just wanted to see if anything we're doing in the field is actually reducing their time to the hospital. So from this here, we have 3,767 initial records that were reduced down to 11. Danny, we're going to talk about that in a second. But essentially, they subdivided these groups, targeting EMS dispatch and clinicians, and then targeting only clinicians, and then targeting wholesale system change. Suspected stroke patients were in the primary population, and they also looked at any changes in the times. Their conclusions was that, based on the study, interventions intended to improve the efficacy of the acute stroke pathway rarely improved EMS call to hospital times, and studies that were included were heterogeneous and rarely focused on the review topic, which limits the feasibility of the findings. So before we get into the meat of this data, what this first block is showing us, what the abstract is showing us, is that there's not a lot of really good data out there to review, which was problematic for this actual review. We've talked before, absence of evidence is not necessarily evidence of absence.
No, absolutely not. And, it's an interesting study. It looked at a lot of different ways of trying to minimize on-scene time. And once we read into the study, there's some novel ideas, but that's part of the problem here, is that we've got a lot of heterogeneity, and it's very hard to measure that. It's very hard to see how everything's working when everything is very different. It's not a bad study. It's the product of its data collection.
Yeah, and that's pretty much right. And again, before we really get into this, once you've seen one study, you have seen one study. This article is out of the United Kingdom, so that population doesn't necessarily translate to the United States, and all other caveats you would like to hear, let's just say that we already told you them. So for these methods here, what they were looking at, you can read all this here. Essentially, they went through Ovid, EBSCO, Medline, and all these places, and did a large sort of analysis of analysis, which is what we really like. As we get down here, this is something that I really like, the risk of bias. They didn't exclude any studies for risk of bias, but one of the issues with it is that the studies were so heterogeneous that nothing really directly applied to EMS, or a very small percentage of them applied to EMS. Here we have their actual process of going through everything. These are the studies that they looked at, which I kind of like this actual paper, this page here. I think it gives us a pretty good N of the patients who were included, right? You've got 942 patients here. Here you've got 17,000 patients for suspected stroke. The other issue you see along here, the risk of bias is fairly high.
Mm-hmm. Yeah, it's a good way for you to look at what they actually looked at and what the findings were and how it measured into the final conclusion.
And so here and in the paper, they talk about the problems with the data, right? So studies that target EMS only. There's a second group that only included 4 studies. 3 of the studies with improved stroke recognition were an element of the intervention. And the only study purely focused on reducing on-scene times. Now, this paper, and this will be linked in the show notes as everything else is. This is one of those papers that the data speaks to the data that they found, which again is not necessarily bad. It just doesn't mean that we might not have enough actual information out here. The conclusions of the study, as we said, they described interventions intended to enhance the acute stroke pathway, but EMS stroke times were not usually improved. Another thing that I want to mention here is this paper was funded by the Stroke Association, which because they're saying that there were no real differences in EMS times, I'm not super concerned about the funding, but it's important to mention that the Stroke Association did fund this paper as we talk about stroke care. So this paper, again, this is from McClellan et al. This will be linked in the show notes. So let's talk about what we think here, Dan. If someone is called, if 911 is called, right, we're going out there to actually assess the patient. We're taught, or at least I think we're kind of guided to think that whether you're doing an NIH or a race score, or even a Cincinnati or a Miami score, that what we're doing matters, right? That we do the assessments, we call the hospitals, we let them know what we see, we let them know what we think, and those patients theoretically will see better care or faster care. And now we have data that shows that's not entirely the case.
Well, maybe it depends. I'm going to paraphrase Dr. Milne and say it depends. They looked at certain programs that were studied. They look at certain ways of minimizing on-scene times, from pre-screening to notification screening to different types of things, to sending extra units with the ambulance crew, and none of those specific things actually improved on-scene times or improved overall time to intervention. That doesn't mean that there's things that we do or don't do that don't make a difference. I hate to use a double negative here, but let me go with this. It still matters to recognize stroke symptoms, to get your last known well and the time of symptom onset, and rapidly transport them to a stroke center. That's what matters. Just like in cardiac arrest, what matters? Getting somebody on the chest, pushing hard, pushing fast, and getting a defibrillator there. And that's what probably we're seeing here, is that a lot of these bells and whistles and these programs, or the people are trying to reinvent the wheel here. And really, this is a public education issue. This is a recognition issue and a rapid transport issue.
And again, the study didn't look at interventions in hospital or outcomes or anything like that. It specifically just looked at if the intervention in the study is EMS showed up to the call and are now involved in the call, did that reduce the time to the hospital? One of the issues I have with that is that I tend to think that people are a little bit of the mind that the hospital, like the door to the hospital, the threshold, is like a magic plane, right? You traverse through the plane and now you're in the hospital and everything's going to be fine.
Right.
So, but we can't know the improved outcomes or even possibly the reduced outcomes without knowing whether or not what we're doing pre-hospitally actually matters. And this isn't to say that the interventions that we can do in the field, and again, without having a lot of the extra knowledge and information in this study, it's really hard to interpret. But for example, this was not analyzed in systems that might give something like a clot buster in the field if they carry a kinase type of drug, or it also doesn't mention proximity to hospitals, proximity to stroke centers, and the United Kingdom system does work very, very differently than the system in the United States, and that's also a principal difference. But in that type of setting, again, it's in England, they're not necessarily as far from hospitals as we might be, certainly not in New Jersey. But I'm not sure that information from this data will translate to, say, Nebraska.
No, and I don't think this is a practice-changing paper. I don't think this is going to do drastic things to how we do things. It's still going to come down to doing the fundamentals well. It always comes down to that, folks. It's the recognition. It's the getting the person to the right place safely and as quickly as we possibly can. And, we used to argue, stay and play or swoop and scoop or run and shoot or whatever they did. Listen, we've got to stop changing. We got to start changing that paradigm. We've got to start looking at care on scene and on scene time as an investment. We are putting money down. We're putting effort down, or an investment in that patient, and we want something on the back end, right? So if we're not doing something in the field that's going to directly benefit that person down the road, the question is, should we be doing it?
No, and I think that's right. And again, without looking at interventions or treatments, I think it can be a little bit difficult to figure out what actually helps in the field. It feels like this type of data, when it comes out, you know, there's always conversations, right, where
Yeah.
it's, okay, well, we have to figure out what more can we do. And I think in the United States, that tends to be more of a function of healthcare economics, where, how can we either improve value to the patient or improve revenue to the system? And
Right.
that's obviously a whole different conversation that we're going to have. But if, for example, one of the things that this paper might help with, or it might hinder with, is if I'm trying to sell an organization on improving stroke outcomes. This is where I think papers like this become interesting, where if I have to suggest that, we should really work to bolster our stroke program, because if we work to bolster our stroke program, patients will have better outcomes and like that. Data sets like these sort of worry me toward that kind of progress, right? It's super easy to sit back here and be glib and be like, hey, check it out. We don't know what the hell we're doing. How strange. Waka waka.
Right.
But I guess I'm concerned that seeing that we don't make any difference as far as this paper is concerned, I worry that that's going to be bastardized into, all right, since we know that we don't make any difference, why do we assess and care for stroke patients at all? So it almost feels like data like this changes the argument from, well, no, hang on. So just because like
Go with it. All right, hold on.
Well, because there's an evolution in the stroke argument, right? Where it was strokes have to be ALS patients because what if they lose their airway? And then that kind of changed to, all right, well, it turns out we can actually probably just M&T most stroke patients, right? We can just monitor them and transport them to the hospital and let the hospital do all those interventions. And I wonder what type of outcome we can find if we're already having that train of thought, and now we're finding out like, all right, well, EMS doesn't reduce time to the door, so what do we have EMS do in the first place? You know what I mean?
I'm going to take the other side of this. I'm going to go back to what I said earlier. I think, remember, this paper talked about things that minimized on-scene time, and it was a lot of stuff like screening tools and bringing extra units to the scene and some other things in the paper that were used to try to minimize on-scene time. And I think the thing to take from a paper like this is that all of those programs and those bells and whistles, and everybody has a great idea, like the good idea fairy attacks. And I think what we're starting to see in the literature, or in the base of the literature that we're seeing out there, is for some of these conditions, what matters is fundamentals. It's not the frou-frou stuff. It's the fundamentals. Look at cardiac arrest. Look at trauma, especially penetrating trauma. Look at stroke care. These are things where the fundamentals really matter, where you have to be on your ball with assessment, recognition, notification, and transport. Same thing with your traumas, same thing with your cardiac arrests. Get public education out there, get somebody on the chest pushing hard and pushing fast, get people to the scene with a defibrillator. It could be a cop, it can be a layperson, it could be a fire truck, it could be anything. It doesn't matter. Right. That's the stuff that matters. And that's kind of what I'm taking from it. And I think it's kind of a positive thing. It's showing the gimmicky kind of things don't really do what we want them to do.
I think there's applicability to we're seeing movements with mobile stroke units and things like that, where, and I certainly think you're right, where, it's fun to have all the big sexy tools, right? It's right. Nice to have, oh, like, look at all this. We spent $400,000 on this ambulance and all that. And now I've got a big expensive toy that looks nice and shiny and doesn't fix anything. Right. It's like buying a Cybertruck.
We can go on about mobile stroke units another time. I've got plenty of,
you know what I mean? It feels like we, and again, I think this tends to be more of a function of, the revenue model, where if we have this big sexy equipment, then we can charge more, thus we can make more money, and then we can do other things. Right. And you can call that cynical, you can call it whatever you'd like. I tend to feel it's the more realistic view. And given that, it's like, oh, well, as long as we have all this extra stuff to play with, then things are going to be better, we can bill more. But if the idea of EMS is to bring first care to the patient and make their admission better, this paper, at least in the UK, seems to suggest that we're not really doing that. So I think the next question is, obviously, any good study ends with more data needs to be done, more research needs to be done. And certainly this is stuff that we need to look at in the United States. But what I wonder, and I guess what I worry about is I don't want to see, EMS isn't doing anything to reduce, dispatch to hospital times. There's part of that
Yeah.
that's geography, right? If someone lives 40 miles away from a stroke center, there's really nothing you can do about that, right? Short of implementing a flight program where now we're flying, ischemic strokes for 40 minutes away from the hospital. And certainly that's a thing that you can do. I just don't know if that's actually going to make the difference that we want to see. So I guess what we have to figure out now is, how do we look at stroke care and how do we actually start to make a positive difference? I tend to think that in situations like this, especially if you're working on an ALS unit, this is where you have like your mobile assessments, right? Where you can do, like, you want to do your primary assessment as the patient is still, so you can establish a baseline. But this is where, even as you're driving to the hospital, you can just ask the patient to pick up their arms, right? If you can pick up your arms, great. You're not having a stroke, or it's not evolving or anything like that. And I feel like interventions like that might be more helpful to the hospital. But this might also be a thing where it's not something that we're doing necessarily, as it is, we can only do so much about where the patients are in relation to the hospital.
I get that, and I understand that, but again, I think what the balance of the studies and the balance of the data is starting to tell us is that the fundamentals matter, and the other stuff is extraneous.
Yeah, and again, I think that's right. And again, if you're out doing your assessment, you're not sure if the patient is having a stroke, this is where your primary assessment comes in. Does the patient have a facial droop? Are they hypertensive? Are they forgetful? Do they report a headache right before they actually had these symptoms? And again, this might also be a function of, a lot of times in EMS, we tend to get to patients after they've already been very, very sick. Right. One of the things that you will run into in data in hospitals is, if someone is sitting in a neuro ICU and they have a stroke on the neuro ICU, of course their care is going to be better than it would be pre-hospitally, because their stroke is being treated 30 seconds after it started. I mean, I'm being hyperbolic, but
sure, the guy who goes into VTAC in the CVICU probably has a better outcome than the person who goes into
exactly. Yeah.
Why? Because everybody's watching. They know when it happens. All the experts are there. They've got access. They've got everything they need. Yeah, they may do better.
Yeah. And again, if this system is operated differently than any of the systems in the United States, then some of the information might not be super translatable. I agree with you. I don't know that this is practice changing. I think it's interesting. And I think it's something that we need to keep in mind, right? So if what we're doing is, even if we're offering the best amount of care, when you're at the bedside with a patient in the field, you might not actually be reducing their time to the actual intervention. And we know that EMS to needle is one of the most important benchmarks in stroke care. So if you're not sure, what the assessment is showing, instead of sitting on scene and trying to reassess and trying to rebuild and making it right for you, you want to make sure that these patients are on the way to the hospital so that they can get the care that they really need. And this also adds to, so what can we do, right, to kind of fix this problem? This is where more like efficiency and streamlining comes in. So if you're at a system where you have direct contact to the hospital you're going to, that's the phone call, right? Whether you're still using a radio, or I don't really care if you're still using like a plectron from the 80s, right? You call in, you're like, listen, we're coming in with this patient with these presentations. If for no other reason, just so the hospital knows about it, where if you're not reducing their time from first patient contact to their actual intervention, you want to at least streamline their time in the hospital.
Yeah, that's it. And that's the fundamentals. And if we're doing them well, we're going to get good outcomes.
Yeah, and I think that's always the biggest thing whenever we're talking about any study or any data here. The fundamentals are arguably the most important part of your patient assessment. And if you do anything well in your assessment, it should be the fundamentals. It should be, your pulse rate, your blood pressure, your respiratory rate, pulse ox, lung sounds, all that kind of stuff. And I think it's also important to mention that assessment should exist for all patients. It's not just stroke patients, right? I think that oftentimes we'll start assessing patients and we kind of default to, this is just a routine assessment. I don't really have to worry about it. And the other thing to keep in mind is that this data set, again, they were only able to pull 11 studies from 3,767 records. So this is also a thing where we're not sure what the actual reality is, because there may not be enough data to actually tell us anything. So let me know what you think about that, and then we'll get out of here.
No, I think you're right. And this is a thing that we're finding out in Journal Club is there's not a lot of EMS data, not a lot of EMS focused data. And we need people to start writing papers. We need people to start researching things. We need you to start going to your program directors and going to your medical directors and saying, hey, we should look at this. We should study it. We should publish it. It's worthwhile. It's worth doing.
And especially if you work at a neuro hospital or someplace that has a very robust stroke program, certainly any good program is going to want to involve EMS in their stroke care. But let us know what you guys think down in the comments. Make sure to subscribe at that one button arrow thing that's going to be on the screen somewhere. The link to this study is going to be in the show notes. And for the Overrun, I am Ed Bowder.
I'm Dan Schwester.
And we will see you next week, Journal Clubbers. Have a good week.
Take care.